I think a really hot topic at the moment in the media are these weight loss injections. I know myself in my practices, we get quite a lot of requests for those. And I know we discussed it a couple of times about how drugs in general can be introduced to the market for one thing, and the evidence shows benefit in one specific cohort, in one specific scenario. And that's great, and that's why it's supposed to be used. But then, due to external factors, great media campaign, great social media campaign, it gets hijacked. And we're now seeing a massive use outside of the original intention. It'd be really great to get your take on it, because I know you've been on a couple of news shows as well discussing the weight loss injections, Waleed.
Yeah, so when we first started with weight loss injections, I would say social media and celebrities were the biggest driving factor. So what would happen is somebody would lose a significant amount of weight, and then there would be talk of, oh, this person's taking this medication. And I remember when this very, very first happened, there was a lot of US celebrities where, my missus doesn't really keep up to date with medical news and stuff like that generally. And I remember her telling me that, oh, this celebrity is so thin. Oh, what's going on here? Has she had lipo? But it's from everywhere. How you can't have lipo everywhere. So, like how does that work? And then it started to come out in the news. They're taking a GLP, they're taking this medication, etc. So I think, and some celebrities didn't talk about it and it was speculative. And sometimes it was an anonymous report that was leaked and all that sort of stuff. And sometimes they just outright came and said it. And I think that plays a large role. What that does is it brings attention to an area. And once you have attention, that then can change whether something moves positively or negatively. So what do these medications do? These medications were designed to be used for patients that have diabetes. That's the first thing. They are shown to reduce the A1C, which is the average blood sugar over a 3-month period, and therefore they're incredibly effective at treating diabetes. Part of how they do that is they help you achieve significant weight loss. And we know with type 2 diabetes in particular, weight gain and insulin resistance play a massive role. And we know that the single most likely thing to help you reverse the condition is weight loss. In fact, there are whole diet reversal based programs where you restrict your calories and then you reverse your diabetes, etc. So we know that weight and diabetes are intrinsically linked. So it's not a surprise that if you lose loads of weight, your diabetes gets much better. I think we always knew that. It's just how do you lose the weight? So that's the first thing. Because of how effective they are, and because obesity in itself is now it's now a recognized disease, right? So obesity used to almost be like a finding or a symptom almost, but we now talk about obesity, the illness, as a condition. We talk about it as an illness. And the reason for that is obesity, medically speaking, is when somebody has a BMI of more than 30. And we know that that patient cohort is more likely to die for multiple reasons. And I don't mean to be morbid here, but we're talking about why it's a condition. So we know your cancer rates increase, we know your risk of heart attacks increase, and so it's been classified as an illness. When you have an illness, you can then treat that illness, right? So what they've now found is, because of how effective it is in weight loss, a lot of these medications now have licenses or permissions and evidence bases for obesity, even when someone doesn't have diabetes. The issue we have is an NHS funding issue, which is these treatments are only available readily for people with diabetes that meet the criteria to have the treatment, whereas weight loss is governed through specialist weight loss clinics. And the reason for that is, historically, your weight loss clinic's aim was to try everything to help somebody lose weight and then eventually offer them surgery if required. When those systems were created, there was no GLP in the equation.
It's a whole new treatment arm. That's just
because the medications that we had available were incredibly limited, relatively ineffective. And so essentially you were trying to gauge diet, exercise, and calorie control and portion control, and then moving people onto a bariatric surgery. That was almost extensively it. So the system was never designed to issue these medications that are specialist now because it's for obesity and not diabetes, and GPs were not allowed to start them for weight loss only. So what's ended up happening is, because of how effective they are, people have started to obtain them privately. So actually most of these medications in the UK are issued privately because the amount of people that qualify via diabetes is very small and the infrastructure for the NHS weight loss services didn't exist. So you've now got people self-obtaining the medication, and often through what I would class as fraudulent methods. So what that means is you are supposed to present evidence, and it's up to the private supplier to obtain that evidence. And they might just say, show us a copy of the scale with your weight on it.
And people do all sorts, like holding water bottles and weights.
Yes,
Yeah.
and people just do anything. Right? When somebody wants something and you don't have an effective, accredited way of delivering it, people that then abuse the system. So I'll give you an analogy of this, right? Like in so many other conditions, if you wanted a treatment in the private space, they would make you come to a center, have an assessment, you'd pay the appropriate price, and then they would objectively verify information and tell you yes or no.
Yeah.
But because this was available online, people just completely abused the way it worked. There was no verification of any details. And as a result of that, you've got people that don't even meet the criteria for the injection, or they've been successfully treated and they need to stop. But there's no safety net, there's no guardrails, there's no mechanism to prevent people from abusing it. And what's happening is people are becoming almost dangerously low in weight. As a result, because there's probably some level of psychological issue, there's a body dysmorphia at play, people are able to control their impulses, or they're seeing success and they want more success.
Yeah.
And there are people where, without coming across negatively, you can see their bone structure, right? Like they've clearly don't need this medication from a weight loss perspective, and they're struggling to stop. And what's happening is, because of how many people are using this medication in a short space of time, we're getting phenomenal data, right? We're getting data that would take decades to obtain. We're getting it very, very quickly. So the first thing is, some of these medications have excellent cardiovascular outcome data, and they're shown to reduce the risk of CKD progression, cardiovascular death, etc. Some of the data is amazing. And I think that's going to position them to help those that need even more. But what we're also finding is, because we've never had a treatment that helps you lose this much weight so effectively, there are considerations that we've never had to have that we now have to have. So we're now finding that because they're losing weight so quickly, they're actually losing muscle mass.
Yeah.
And we've never had a treatment that is so effective that you're losing weight too quickly. And what I think will need to happen very soon is there will almost need to be a expected projection of weight loss to say, this is how quickly you should be losing weight. And if it's more than this, stop the medication or drop the dose. Because people, when you lose weight too quickly, you burn through your carbohydrates, you burn through your fat. And what's next?
Your muscles, isn't it?
Your muscle, right? So people are losing so much weight, and because they're not eating anything, because it's restricting their appetite, they're not keeping up their protein content. People are going a day or two without eating sometimes, almost facilitated fasting, right? And so they're losing muscle mass. And what people are unaware of is, when you lose muscle mass and you're relatively young, you speed up the decline of your bones. So your bones are only healthy because you're putting weight on them and because you're using them and there's muscle attached to them. When you're losing a lot of this weight, your risk of osteoporosis and brittle bones significantly increases. So I'm really worried in the next 10 years about what's going to happen to our osteoporosis rates, what's going to happen to bone density, how easily people are going to fracture their bones. And obviously, if your bone mineral density is really, really reduced, even the corrective measures like surgery are less successful, because the stuff you're going to drill into isn't going to be good. It's not going to be good quality, right? Yeah. We don't have any infrastructure around, if these people are having this treatment, checking their bone quality, doing DEXA scans, starting them on bone strengthening treatments. So if you've got somebody with, so let's not take the extreme, let's take a normal example.
Yeah.
Or an intended use case example. You have a person with diabetes who's significantly overweight. They appropriately qualify for the treatment and they've started the treatment. Great. Because they have diabetes and you want to keep the weight off, they're probably going to continue with this treatment for life, in all honesty, right? And we'll come back to that because that's important. So they're going to carry on with the treatment for life. They've lost their weight, the diabetes is well controlled, and they can't come off the treatment. Great. But what we don't then have is, when do we stop or when do we reduce? How do we monitor that? And how much weight should they be losing and why? And if they're on the treatment for a certain period of time, what are we doing for their bone quality? Does this person need a multivitamin?
Yeah.
Right? Do they need some form of additional nutrition replacement?
Because if you think about it, now you mentioned the weight loss treatment algorithm that we used to have, and it ended up in bariatric surgery. What do we do with patients that have had bariatric surgery afterwards? They get monitored for their zinc, for the vitamin Ds. but that doesn't exist.
Yeah, so we know when someone has bariatric surgery, they need lifelong B12 injections.
Yes.
We know they need iron supplementation. We're not doing any of that
No.
for these patients, right? They're not eating, they're not taking nutrition, their bone loss is going to be a major issue. We're not replacing their calcium, we're not DEXA scanning them, we're not checking anything.
The earliest that will be is when they fall, have a fracture, and then it's retrospectively going back to the point of being very reactive here.
Yeah. And because the data is available, I feel like we're waiting for some high profile problems to happen before this normally, or what in the NHS, normally something needs to go wrong a lot for you to then do something. So we know now that bone loss is happening, and we know now that muscle loss is happening.
Yeah.
We should be doing something like proactively about this. Obviously, we're not. I guess my other issue is when you look at when to stop treatment or how to do things in the private space, a lot of them are stopping the treatment after 2 years when weight loss has been achieved. But what the studies show is, and they're both showing very, very similar things, but there's between a 60 to 75% weight gain, like regain, within 12 months of stopping the medication. And what they have shown is that even when people have tried to make sort of lifestyle dietary interventions, that number doesn't really improve. So essentially, without overcomplicating this, when you stop the treatment, it stops working and you pile the weight back on. That's a very, very simplistic. There's obviously, 15, 20% of people that have managed. And the longer you're off the medication, the more weight keeps coming back. So they just did a 12-month study, but when you look at 2 years, there's an additional amount of people that have regained weight as well. So, and it makes sense because if your appetite's not being suppressed, you eat.
Yeah.
Right. And these people had a propensity to put on weight, which is why they were obese to begin with. So you've not changed your genetics. You've not changed the fact that you gain weight quickly or that you have a certain appetite. So this is a temporary measure. So people that are taking this medication, realistically, they're on it for life if they want long-term benefit, right? This isn't the kind of thing where you get to a weight and then you stop. We know that 4/5 of people regain their weight, and there will be 1/5, and I'm sure everybody wants to be that 1/5, right? That 20% that is the success story. But when we make healthcare decisions, we generally make them for the majority. So you see the extreme of this, right? Where you had almost phase 1 of the GLPs that were really, really effective in weight loss and A1C control. And then you had the newer phases that were even more effective. And then everyone sort of clambers for the thing that's, most recent and most effective. And then you have this new drug, retatrutide, which is currently still in trials. I can't remember if it's phase 3 or phase 4, but it's still, it's testing stage still. And it has been shown in the trials to be very effective. But it's a trial for a reason, so the reason we trial things is something works well in like animals, and then you see if it does the same thing in humans. And sometimes the whole reason we do this is when you test it in humans, you find out things about it that you didn't know.
Your side effects, your tolerances, all that stuff.
Exactly. So it hasn't finished testing. And usually a drug would go through testing and you would establish that it's completely safe and it's, above board and there's nothing, horrible to be worried about. And somehow, and I don't know if it's the actual drug or a counterfeit version of the drug or whatever, but it's been obtained. And I think this is a real liability issue, because my question is, how on earth have large volumes of an unreleased drug been obtained consistently?
Yeah.
To me, there's a leak somewhere, right? Like, as in there's somebody siphoning off medication on a side point here. And I think that from a criminal perspective really should be investigated in terms of why has that been allowed to happen, firstly. And secondly, people that are selling medications that have not been licensed. So a treatment should be tested. It should be proven to be beneficial. It then should have expert panels approve them. And we have an organization called the MHRA that does this in the UK, that will approve a medication, and then it will sort of check to see if it's okay and it's within a license. And the license might be, this medication, based on assessment, can be used for a diabetic person, or it can be used for someone that's overweight, or it can be used for a different indication. And then you develop a pathway for how you can use it. None of that has happened. No assessment of this drug has happened and people are taking it. And this comes down to experimental care, doesn't it? You should be allowed to do something in the private space if it's legally allowed. But if a medication is untested, not got a safety profile, and it's not been licensed, we as a country are not doing enough, right? Because this should be the kind of thing that people are fined millions of pounds for, and people should, like, and this is going to sound really extreme, people should be in prison for this, as far as I'm concerned, because people are going to want what they can have access to, right? Let's pretend this is the correct drug, and let's pretend we're a few years in the future and this drug is safe, because that's what obviously what they're assuming. So that's all fine. But why has it been allowed to enter the market? And what are we doing to make sure no one's ever incentivized to do this again?
Because that's the precedent.
Yeah.
There'll be another drug in 2, 3, 4 years, and that happens again, and people are profiting from this.
Yeah.
Clearly. So
and I think, in any other space, selling something untried, untested, unlicensed, not allowed, illegally, you would hope has major consequences.
Yeah.
But I'm seeing that they found a warehouse and this warehouse had the product. What are we doing about it? Do you how we should be? Is this coming in via boat? Are we blockading it? Are we obtaining it? If this was, and I don't mean this to sound pedantic, right? But if this was like cocaine, we'd be having a whole different conversation about it. And this is a medication that we just described causes muscle loss, causes weight loss, can cause pancreatitis, can worsen retinopathy, right? So it can make people's vision worse. There's lots of things to consider here. And I don't feel we are policing this sector closely enough.
It's a public health safety issue, isn't it?
Absolutely. And I think we need to be stricter and have more safeguards for things like this. One very quick example is I'm sure people are buying this from TikTok, or they're being directed to it on TikTok. And I think there's a precedent for what information should be allowed. And I'm not going to say that we should necessarily censor information, but I know there are countries that will only allow certain information to be posted if it's been verified. So, for example, in some countries, if you want to call yourself a healthcare influencer, you have to either have a qualification in healthcare, or the information that you post has to be vetted by an educational organization. So at least there's no risk of misinformation. Because when you have publicly free misinformation circulating, and I don't mean to digress here, this is kind of the reason why people are not vaccinating their children. This free availability of misinformation has massive detriment from a public health perspective. And look at, we now have measles outbreaks, and we thought we eradicated conditions like these. We had a 0 incidence rate, and now you've got whole hot sections where you've got conditions that are entirely preventable making a resurgence. And we know the consequences of not taking these seriously from a public health perspective.
And the issue is, it's not damage that can be easily fixed in, a couple of months. This is 10, 15 years down the line. We'll probably see all the consequences of this.
Yeah. And then I'm sure we'll have a new reactive policy at the time.
Yeah, probably. We have massive waiting lists for everything, isn't it?
Yeah, we'll have a consequence of untested GLP waiting list.
Yeah.
And then talk about why is the waiting list so high.
Will you be in a steering group?
I'll try my best.